All right, everyone. Welcome back for this lecture. And continuing on the phases of an EMS call and EMS assessment, we're going to be talking about history taking. Now, keep in mind that I've already discussed kind of the phases of the EMS call. We do primary assessment, and transport decision, and vital signs. Now we're going to talk about history taking. Remember that once we make our transport decision, vital signs, history taking, secondary assessment can all be done simultaneously or kind of mix and match depending on where you are in the patient care and what's needed at the time. So, unlike vital signs, with history taking, we're going to be talking predominantly about subjective information, qualitative information. Remember that vital signs are something that we can physically measure, while history taking is a subjective experience. And so this is going to be when you are interviewing a patient, when you're gathering information about their chief complaint, right? That the number one thing that's bothering them the most, or the mechanism of injury, or whatever that may be. This is where you start to interview the patient. And this is ultimately what's going to drive your secondary assessment, particularly in medical patients. Trauma patients, it's kind of what you see is what you get as far as injuries are concerned. With the medical patient in particular, you're going to use the history to sort of drive what you're looking to assess, to identify or confirm your suspicion level, okay, your field diagnosis. Again, keeping in mind that we're going to be using the index of suspicion here. So we're going to be using our assessment skills and our history taking and our vital signs to raise or lower our index of suspicions of how critical the patient is or what may be with that patient. The two acronyms that you predominantly see are going to be sample and OPQRST in history taking. Now, understand if you're just starting out in EMS training at the EMT level, that memorizing sample and OPQRST is a great way to get yourself started. It helps kind of get through the flow of things, make sure you get the most pertinent information. But as you develop as a practitioner, clinician, particularly if you're looking at, if you're using this video series and you're training up to the advanced EMT level or the paramedic level, then you're really going to want to start to hone your interview skills and using sample as a springboard just to get yourself sort of started, right? The ability or the skill to interview a patient is really crucial in being able to form that field diagnosis, be able to drive your assessment. So if you're just starting out, let's start with sample OPQRST. And then as you get more proficient in that, you can start to use that as a springboard to dig into two places that are largely overlooked in EMS assessment is paying attention to the patient's social history and their family history. Now, family history is not always overlooked. Sometimes, especially for cardiac events, acute medical problems, people will oftentimes, EMS providers will oftentimes ask about familial history. But it's always a good thing to just try and gauge, even if the patient is sick, right? Once again, you're the only provider that's going to see this patient in and where the emergency occurred. So information that you can gather, other folks in the healthcare spectrum, as they're taking care of this patient or the continuum of health, may not have access. And social history we've talked about a lot, right? So talk a little bit more here about it shortly again, but patient have food insecurities? Do they have access to clean drinking water, to their medications, to regular medical care? All of those things become important about the acuity of health needs for this particular patient may be taken care of. So with that, let's start out with sample. So sample is a pretty straightforward acronym for you. The S stands for signs and symptoms, right? So signs, things that you can measure, right? So think vital signs, right? And then symptoms are what the patient complaint is, right? Good way to do this is when you introduce yourself to the patient. Hi, my name's Austin. I'm with EMS. What's got me out here today? What's going on today? Patient's going to tell you what's wrong with them, right? Or a family member if the patient is incapacitated. Okay, those are your symptoms, right? And then you're going to want to let the patient. One of the big thing is make sure the patients, you let them sort of tell their story. Okay, ask open-ended questions. Don't walk up to a patient. This is something we see a lot with new providers, particularly. You get dispatched for chest pain. You get on scene. You say, "Hi, I'm Austin with EMS. I hear you're having chest pain." Then you have some confirmation bias from the patient there, and they may not tell you exactly what's wrong. It's much better to have open-ended questions. Let that patient tell their story. Other pieces within sample are allergies. We want to remember they have any allergies to medication, but also allergies that may be relevant to their complaint. For example, it's summertime and they're having trouble breathing after they were outside mowing the lawn. Are they allergic to bee stings or something that may be relevant there? Medications. This needs to include medications that they're taking that are both prescription, over the counter, and supplements, as there are a lot of medications, particularly for you guys going through paramedic education. There are a lot of OTC medications, supplements that are contradictory or can have untoward reactions with medications as a paramedic. So you need to make sure you ask about past pertinent medical history. In the early part of this, asking the patient, what's your medical history? What have you seen a physician for? And then digging a little deeper can be helpful. Sometimes you have to redirect the patient though. For example, if you're out for patient has a cough, you don't necessarily need to know their childhood surgical history. That may not be relevant for you. So that's where that word pertinent. Then your last oral intake, right? Anything, okay? The events that have led up to the event. So you're out there for, a toe pain or something, and well, what happened before your toe started hurting and kicked the bed? Okay, well, that's pertinent. That's relevant. If someone has been nauseated, you may want to ask them about what did they eat? Have they eaten something different? What were you doing before you became nauseous? Were you on a merry-go-round? Something. Use that as an opportunity to just try and get some more. And then I like to include plus, and so I really like to do sample plus, because sample really, like I said before, should be a springboard for you to start asking more pertinent questions. Make sure you avoid yes/no questions, okay? And give the patient, again, an opportunity, a chance to tell their story. Other thing to keep in, not every question is relevant, okay? If the patient is, perhaps really critically sick and not able to really be coherent, answer questions, and you don't have a bystander, you may not be able to get their past pertinent medical history. They may not be able to tell you about their medication. But one of the things you can do is in your scene survey, right? Look for those medications, look for clues. Remember that medical history particularly is about being a detective. The next thing that we'll use for the medical history is the OPQRST. So OPQRST, your acronym. O is for onset. An onset is different than time. Onset, did this come on rapidly, or has this been slowly over? You're on scene for a patient with nausea and vomiting. How long have you been feeling nausea? Did it come on slowly? Did it come on rapidly? Were you getting worse or for days, or was it immediate? That's what we're looking for. E is for provocation, and provocation meaning is anything that you've done made it better or worse. Okay, so if you're having nausea, eat. Do you feel better? Do you feel better if you drink something? Does it feel better after you vomit? After you go to emesis? Okay. Quality is one that gets people, and I think one of the important things I want you to understand is that not every one of these questions is going to be relevant, nor is the list exhaustive. Okay. It's going to be hard for someone to quantify the quality of their nausea or the quality of their shortness of breath. I don't know. I just can't breathe. Okay. So that may not be a relevant question to ask that patient. Likewise, radiation. So when we talk about radiation or region and radiation, we're talking about and this is for pain really only. Does it go anywhere? So if your chest hurts, does that pain radiate outward or radiate in? So again, for complaints like nausea and vomiting, for shortness of breath, this is really not a relevant question. So you should be thinking about it, but you really shouldn't be asking the patient. Okay. Severity, again, this is mostly used for pain. Talking about severity of shortness of breath, for example, that's going to be used in your quantitative tools, with oxygen saturation, respiratory rate, and quality. That's how you're going to get the severity of a respiratory patient. But in a pain scale, right, that becomes important, or in pain, severity becomes important. You should ask them to rank their pain on a scale of 1 to 10. And then it's helpful sometimes to ask the patient, okay, if you gave this a 7 out of 10, is this the most pain you've ever experienced in life? And if no, then you can say, okay, well, what would a 10 be? That will help you quantify the amount of pain. For patients who can't speak, or particularly pediatric patients, you can use things like the Wong-Baker Faces scale or score, and that helps you get an idea based on grimace or the facial expression of the patient, what level of pain. Time, again, different than onset. Time is how long. And again, putting the plus sign in here, so you can use it as an opportunity to say, I might need to inquire a bit further. Okay, let's talk about social history. Okay, we know that based on evidence that we have all over the world and throughout human history, that a person's access to clean water, food, medical care, okay, to their education level directly correlates to their quality of health and health factors. So not every patient are you going to ask these questions. These are things that you may want to evaluate around the scene during your scene survey history. And this is an area where community paramedicine focuses significantly, is on social history. Okay, because some of these things are ultimately they're not always immediate concerns that need to be addressed, but they're preventative measures and preventative factors so that we can allow a patient to have a better quality of life and ultimately have to use the emergency health system much less. So things that you want to keep for, things like food insecurity. Look around and see if the patient has food. Not uncommon going to a welfare check for a patient or an elderly patient that may be a frequent user to talk to them about, do you have access to food? Being observant on whether or not they have power, running water. Again, I think if you're new to this field or you're coming into this field, you're surprised at the number of people you see within your career that are within this country in relatively affluent areas and cities that have no access to power or running water. Of disheartening, sure, the amount that we see. Trip hazards, particularly for the elderly. Right? Take a look around, and if you keep going out to a patient that you've got to assist off the ground, and take a look around. What are the hazards around them that you help them move? Right? Perhaps the set of stairs going into their house is difficult to navigate for them. They're strong as they were. Start to develop resources or a list of resources within the community that you can reach out to get these patients some assistance. A lot of times local churches, community centers, local philanthropy groups will all have funds available or resources available to help these patients. Sometimes it's as simple as helping an elderly person pick up the rugs, getting them a pair of non-slip socks. Remember that you're there in a patient's time of need, and whether that need is an emergent heart attack or respiratory distress or cardiac arrest, catching the patient before they get to that, right, and being able to intervene and prevent that and increase that quality of life. Also part of our job. And then think about healthcare literacy. Is the patient aware of their medical conditions? Not uncommon to have diabetic patients that may be sick and not feeling well and are not eating, but they still want to take their medicine, right? That's definitely not a good thing. And as we get to diabetic emergency, see some of that, and we'll talk about that. But patients need to be aware, they need to be literate of their conditions. And so sometimes doing some education, some outreach can be very helpful. So that's another thing to consider within your social history of your patient history. The family history can provide insight into risk factors. It's not always relevant, but it certainly can be helpful when adjusting your index of suspicion. And this is really common when we talk about things like coronary events or heart attack. Got a relatively young, healthy patient that, gosh, is really young to be having a cardiac event. But then you ask, did anybody in your family have a cardiac event? And they tell you, father died at 40 from a heart attack or something along that. Gives you a really good opportunity to gauge potential for problems. It is certainly information that should be communicated in the continuum of care. So as far as the index of suspicion goes, right, remember to be a detective. When you find a door, you find an opportunity to get information that seems to be relevant for what's going on, open the door and let the patient tell their story. Okay? Walk through the door and let them go. The most information you're going to be able to get is when that patient is not guided or prompted, but they're able to tell you about what's going on. As we talked about earlier, check your bias, right? Just because it's not an emergency to you doesn't mean it's not an emergency for the patient. Okay? Their perspective, what matters, not. Make sure you're using open-ended communication. And just remember that your definition of an emergency is a relevant definition. They think it's an emergency, they need your assistance. We are there to assist as a part of the community system. All right, see you guys in the next one.